right, thank you to PK for allowing me to be part of the meeting again. So, the more that you do this sort of thing, these are my disclosures, the more you start to realize that you have a lot of questions still unanswered. So I'm going to try to make it simple. I've tried to make my life simple as much as I can. So when you look at options here, I think you saw a great demonstration of combo femoral radial access. You can use brachial. I don't think anybody in here probably does a lot of brachial. And then there are people that will do these cases tibial. I mean, it is doable, tibial radial. I don't think that's a great way to spend a lot of your time, but you certainly can. And so here's a case where you just have to start making some decisions. You've got lots of disease. You have common iliac disease. You have external. You have common femoral. So you have to decide on what you're going to do. So the common iliac segment here is going to be difficult to do ipsilateral because of the access on the right side. So you're going to need to figure out a way to do some sort of combination of fixing things contralateral and then coming back ipsilateral if you can. And when you're case planning, you just need to know all of this stuff ahead of time. You need to know what your radial artery status is. You need to know how much disease you have and at what level, how severe it is, the complexity of the lesion. Patient height comes into play, especially when you're talking about radial access. And then you just got to figure out how many access sites you need and prep as many sites as you can. Because when you're doing these cases, you need to have your tools and then you need to have your concerns, right? So you need to always be concerned about your access. So you want to look at sheath sizes. We just mentioned the wiseness of the operators here on going 7 French. So you need to be big enough to get the access you need to succeed, but to also be ready for complications, right? Because that's something you have to keep in mind and be concerned about. And then in terms of wires, I know there's some people that do 014. I tend to use more 018 and 035. I just don't find that 014 gives you a big enough body or good enough body to cross a lot of this stuff. You need to have a full complement of support catheters. And then you need balloons, including something to occlude the aorta if things really go sideways, because that's going to be an emergency. And then there's going to be emerging data, on specialty balloons, DCB, IVL, and then a full complement of stents, right? We've talked about the virtues of self-expanding, balloon expandable, and covered stents. You need ultrasound for access, and you need IVUS, because IVUS will help you size and come up with the best plan possible. So here's how I approached that initial case. I went up and over, took care of as many segments as I could, and then you still have this right common iliac that you have to deal with. So that's where the combo access comes into play, where you can actually fix this via a radial approach. But you have to have a big radial artery. So this is how we did it. The 6 French on this particular case, because I used a balloon expandable stent, was okay. If it was going to be a Viabon or VBX, it wouldn't have been good enough. And at this time, we didn't have the super long sheath. So that's another problem when you do radial cases, is you've got to have a long enough sheath to actually get down and do the work. But anyways, so combination radial femoral worked in this case. Another complex iliac case, 54-year-old guy, smokes, works construction, has horrible bilateral SFA occlusions that reconstitute below the knee, and then now had severe claudication, erectile dysfunction, and rest pain. So here's the initial shot. So he's flush occluded more or less on the left common iliac. So again, you have to decide, what you're going to go with in terms of sheath size, wires, balloons, support catheters, and so forth. So how I went about this is crossed with an 018 wire and support catheter, took a picture like George did in his case in the aorta to ensure that I was where I needed to be, because you can be fooled. And so before you start ballooning, you should make sure you're in the aorta. And then from that point on, switched out to bilateral 035 wires, ballooned, and then used IVUS, which demonstrated the size of the vessel so that I could hit it with a 10 by 59 balloon expandable bare metal stent. And whether that was right or wrong, I think there's some economic arguments that need to be made that are germane to this discussion in terms of just using covered stents all the time. I mean, if you're a steward of the CV service line, you have to do it in a somewhat economical manner too. So IVUS guidance does help, even with task D lesions, in terms of following them longitudinally over time. So that's probably why we should use that. You notice a little ding in the aorta there. There was no pressure gradient, so this was the final result after putting a self-expanding in that right iliac. But as luck would have it, 10 months later, comes back, and that stent's shut down. So now what are we going to do? And what is the goal, and what are we worried about? So we're sort of worried about all of the same things. We worry about making sure you're armed for complications, but you need to get a good result, hopefully without jailing the internal iliac if possible. I know it's not the end of the world, but I think vessel preservation is always good. So when you start to think about crossing these things radial, again, very important to have a full complement of equipment that can actually get from the radial to where you need to work. So cross from a right radial approach, you see this profunda, SFA is occluded, reconstitution, then it's gone again, and then it reconstitutes again at the perineal and posterior tibial. So what you're doing here is just trying to improve iliac flow, but this is ultimately going to need surgical intervention too. So I did protect the right side with the radial wire, and then ended up putting a covered stent via 7 French left common femoral access, and ended up with that as the final result. So quickly, another complex iliac. So on these, and you could try any variety of things. You can come radial, you can try to come contralateral, femoral. It's basically up to your comfort level and what you feel like is going to give you the best chance of success. What happened here is ended up crossing from both directions in and out. And so once I had crossed the lesion and actually had externalized the wire out the right common femoral from the left, I had to decide which side to work from. So did an angio up that side and did not really like what was going on there. So I decided to fix it from the contralateral side, which fortunately turned out okay. But that's a little bit of lady luck when you cross contralateral on that and you externalize the wire and so forth. So that could have been done any number of ways, but that's how I did it. And here's something that I think a lot of us see. It's a little more standard. So I think most of us would probably go for it from a femoral approach, but you certainly could try to come down and cross from radial. Again, I've had really good luck with 018 wires and catheters. I think 035 is not only a viable option, I think a lot of people would do it. My only word of caution would be that if you're using a 035 glide wire and a support catheter, if you don't get through it the first time and you start dissecting, you're just always going to find that same dissection plane. So I think it's just whatever you're comfortable with. Again, I think once you cross, make sure you know where you are in the aorta before you start to balloon and do all sorts of things. And then once I cross, there's a couple things that, I think in retrospect I would have done differently. And I know there's obviously a lesion there, but the point I'm trying to make is I needed to protect. This is a good time to put a wire up and protect before you start ballooning right there. Luckily, I got away with ballooning it open and then put 2, again, bare metal balloon expandable stents, and went up both sides with IVUS and ended up with a decent result. And so with that, thank you.